Uh, Good evening, everyone. And like Oliver, it's a pleasure to be here and to be hooking up in this way. That I think we can thank COVID for the technological advances we've made in getting a message out to a large number of people. I've never met Oliver, and we've certainly never compared notes on these presentations, but I am relieved to tell you that we're singing from the same song sheet, and it's sort of a relief to be the second speaker and to know that you're going to say things that are absolutely in accordance with the person who's gone before. So I'm going to focus a little bit more on relationships and intimacy and sexuality because they're important and they're a legitimate aspect of everyone's life, because we all have a sexual identity. We may not all be sexually active at any one time or any given time in our lives, but we are all sexual beings. And what the literature in oncology tells us is that health professionals are very bad at addressing sexuality and intimacy. And women and their partners tell us that they'd like much more information and support about these aspects of their relationship. So if we look at the literature, sexuality and intimacy concerns are frequently reported as unmet needs by couples. You and your partner probably feel uncomfortable raising sexuality concerns with health professionals. What on earth will they think of me? They're trying to save my wife's life or my partner's life with her cancer. I have no place asking about our sexual relationship. But I'm here to tell you that the healthcare professionals probably feel just as uncomfortable about having that discussion with you. But if we can start these awkward conversations, if we can start to communicate, we can improve sexual function and satisfaction, really usually just by providing some information and some fairly simple strategies. We'll talk towards the end about what to do when you need more than the simple strategies, but for most couples, simple strategies will get things back on track. And we know that sexual and intimate practices can be adapted to accommodate the many changes that happen while you go through cancer treatment. So we're really looking at how you adapt to change, because once you heard the words ovarian cancer, you were physically and emotionally assaulted. The changes are huge. Some of them are permanent changes, some are temporary, but none of the changes that have happened to you are unwanted, they're all unwelcome, and they're beyond your control. And it's really difficult and stressful to adapt to change. But a cancer diagnosis, although it takes away so much, and you know this, you know that the person who's being treated loses a lot of independence, therefore so do you. You can lose or reduce employment. Financial security is a problem frequently. Your future plans are just non-existent now, and it's difficult to make more plans. Bodily changes happen. If you've got a stoma or an ugly scar or indwelling venous access devices, and it takes away hope. But what we want to do is not to focus on the things that it takes away, but to look for some strategies to embrace change and find ways for opportunities for growth. Not the way that you would have chosen to improve yourself, but the cancer itself is unchangeable and it's chaotic. But what is it that we can maintain and control and enhance? And the answer to that question is the things that are in our control are relationships, intimacy, and sexuality. So for this purpose, for this presentation, it's a broad definition that I'm taking of sexuality and intimacy. It includes sexual behaviour, sensual activity, and emotional intimacy. So it's not just about whether or not you can achieve penetrative intercourse. Sexual anxieties and problems are common in the general population. We generally don't talk about them, but over the course of most people's lives, there will be some times at which sexual problems arise. They're expected and they're normal. And unfortunately, once they become entrenched, there's distress in relationships, persistent dysfunction, and then the whole intimate relationship can be lost. But there is good news, and that is that some form of sexual expression is always possible if you and your partner desire that. What are the impacts of cancer treatment on sexuality? Not just ovarian cancer treatment, any cancer. There's the direct impact. So there are changes to your physical functioning, there's changes to your interest in sex and your partner's interest in sex. There's things like pain and nausea and menopause. There's indirect impacts, so changes in hormone productions, the fatigue that comes for you and for your partner with exhausting treatments, the side effects of treatment, and if you're worried about finances and about care of your children and how your adolescents are responding to this new stress in their lives, then you're not going to be very focused on your sexual function. The emotional impact, I won't go over that too much. That's really what Oliver's been talking about. But it can be compounded in ovarian cancer by changes to your fertility plans, by body image changes, and fears in you or in your partner about maybe transmitting the cancer. That's not a rational fear, but it's certainly one that we hear a lot about causing pain or causing recurrence. Again, no evidence for that, but it's if we talk with people on their own, then they will tell us that these are some of the worries that they have. And if you had a pre-existing problem in your intimate relationship, well, the cancer isn't going to make it any better. So we all have changes with sexual function over time. That happens with the evolution of the relationship, with things that happen with age-related changes that affect sexual functioning, limited information on education or education on anatomy and sexual functioning, which you would hope might be improving with this current millennial generation, but in some of the younger couples that I see, I don't think it is. But then, let's take a broader view. You and your partner may have other health problems. There might be diabetes or vascular disease, impotence, erectile dysfunction. Maybe there's age-related changes where it's more difficult to maintain sexual function. Most drugs, which include prescription medications and alcohol, are not good for sexual function. Your spiritual, cultural and religious beliefs come into this, as well as environmental factors. If the in-laws have had to move into the spare room to help you with managing the kids and the housework, then that's not very good for your intimate relationship either. If your level of sexual education and your knowledge and skills weren't terribly good before the cancer, then this is a real opportunity to do some learning. All medications can affect and usually negatively affect sexual functioning. So if you or your partner are using narcotic analgesics, if either of you are using hormone drugs, the oral contraceptives, antidepressants, antipsychotics, sedatives, just about anything you can think of, including the chemotherapy itself and the recreational drugs, can make sexual function decline. So what's changed for you? And think about this, we're obviously not going to ask you to tell us this, but what's changed for you? The common things that I hear is that both the women with ovarian cancer and their partners have a decreased libido. And that can happen during treatment, and that might be okay for a short amount of time. But what are you going to do when the treatment's finished and you're wanting to restore some normality, when you're wanting to take some control over the things that you can control in your life? One of the things that happens with couples, not just with cancer, but a fairly common problem, is desire discrepancy. So mismatched libido, where one person is not as interested in sexual behaviour as the other. Talk about it. If sexual intercourse isn't any longer going to be possible for a short period of time or for a longer period of time, then what else is there in your intimate relationship that you can give and receive pleasure? And then if there are changes in physical appearance, in your fertility plans, in your menopausal symptoms or low mood, then life is going to be quite difficult in trying to get your sexual relationship back on track. So we know that cancer treatments almost always have a negative impact on cancer, on sexuality and intimacy. So you should expect the worst, but don't accept it. What are the things that are still good in your relationship? Not just the things that are different, but what are the things that brought you together in the first place and that are still there that you can rekindle now? So the commonest problem in sexual function is poor communication. We might not be very good at telling each other what it is that we want to do in terms of increasing the range of intimate activities that are pleasurable for us and for our partners. Have a conversation with your partner. What's changed for her? She probably feels like she's not the person she used to be and that you see her differently. And no matter how much you can tell someone who's lost their hair and who has a large abdominal scar and maybe some lymphedema and perhaps a colostomy, that you think they're just the same person that you've always loved, that may not be the way she sees herself, and that's okay. Maybe your values and your priorities and your attitudes have changed. How you saw your future is different. Maybe you or she feels really disconnected with others, that although there are a lot of people around you offering support, you feel alone in the crowd. The woman with cancer will often feel that very vulnerable, disappointed in herself and in her body, and have some really understandable body image and self-esteem issues. And she needs to hear that they are validated, that it's okay to feel bad about the way that you look. And that will create uncertainty in relationships and sexuality and intimacy. But this is a webinar about you, and I think that we're not very good as health professionals in really teasing out what are the specific needs of partners, because we see them often, and you may see yourselves as care providers rather than people in need of support yourselves. You're probably protective of your partner, and you may feel reluctant or even embarrassed to disclose that you have needs of your own. There is an inevitable increase in the physical and psychological burden of caring for someone with cancer. In fact, in the literature, you partners have been called second-order patients with levels of distress and anxiety and depression around about the same as the person being treated for cancer. And it is simply exhausting being a cheer squad. You may not have good formal and informal support. The people who are around you may feel reluctant to talk to you about what's happening in your life for fear of upsetting you. You need to be the one who reaches out and tells people what it is that you need. You may have health problems of your own. If this is the first encounter with the healthcare system, it's pretty overwhelming and very difficult to understand. Who are all these people who look after your wife? What is a registrar? What's a clinical trial? How do we get from one institution to another? Where can I go to get assistance about these things? And there are probably a lot of myths and misconceptions and stigma, particularly when it comes to sexuality. But if you feel burdened, and you may also feel guilty because you're not the one who's having cancer treatment, and why should you feel that bad? And the bottom line is that you're fearful about what the future holds. So in terms of your sexual and intimate functioning, what are your worries? Are you worried about causing pain or about being seen to be demanding? These are questions you need to ask your partner. Is there a lack of flexibility in negotiating sexual changes to adapt to the physical changes that have happened? Or are you still assuming that your sexual relationship will go on as it has over the years of your relationship? It may be that you actually feel less physically attracted to your changed partner, and you need to work on that to overcome your expressions of affection and intimacy. And roles do change during and after treatment. So there's a lack of private and enjoyable time together. And probably deep down, a grief and fear about whether the illness will progress. So I've said that we can take control and we can change things. So the first thing is to get out of that thinking that sex is not just penetrative intercourse. There are other sexual practices that you can think about. Be creative. Go back to your courting days. Look at intimacy and non-genital touching. Seek information about using aids that you might need to address some changes. So you might need to use vibrators or lubricant or dilators. And perhaps you need to acknowledge that your underlying relationship is the issue. And if that's the problem, then you need to now seek counselling, couple counselling, to address these concerns. But communication is the most important step. So like Oliver said, schedule some activities. Spontaneity has gone, probably, at least for now. So what else can you do? Some relaxation, some massage, music, dinner for two, different positions. Look at body image, ways to enhance body image so that you're covering up stomas and scars and hair loss. Find out what aids you can use, whether they be medications or hormonal treatments or lubricants. If pain is an issue, then time your pain relief medications so that sex can happen when your partner is more comfortable. So it might not be the end of the day as you fall into bed after a long and busy day at work now. It may be at different times when you've organised to have the children taken away for a weekend or booked yourselves into a hotel for a nice night together. Do you need a specialist sex therapist? Probably not, but a small number of couples will need referral to specialist services. So if you had pre-existing sexual difficulties or relationship difficulties, if you or your partner have a history of sexual abuse or other psychological issues, this is a prime time when they might just bubble to the surface. If you or your partner had a sexual disorder, or simply if you feel more comfortable talking about your sexual problems with a specialist service that isn't available or not associated with your ongoing cancer treatment. So a small number of people will need referral to a specialist sex therapist, and you can get that by asking either your GP or your specialist. So this can be a time for positive adjustments. If you can conquer relationship changes by living through this traumatic experience, then what you might find is a renewed appreciation for life and a hope for the future. Closer, not more distant, intimate relationships. New perspectives about your future directions together. Increased personal strength and resilience, but as I said before, not the ideal way to build your character. And improved lifestyles and behaviours. Always remember, the brain is our biggest sexual organ, so address the thoughts and the cognitions and the myths and misconceptions. The greatest barriers to good sexual functioning are anxiety, ignorance and misinformation. Intimate relationships can be maintained and even improved. Don't suffer in silence. Your care from the cancer health professionals should incorporate permission to address sexuality throughout all stages of treatment and recovery. It's a valid issue for all people, no matter how old you are, what your gender is, what your sexual preference is, or relationship status or health status. If you can communicate and adapt sexual practices to accommodate treatment-related changes, then you can keep a partner sexually satisfied. So the take-home message from me is accept the enormity of the ovarian cancer diagnosis. Give yourself some latitude. Set realistic tasks and goals for sexual recovery. Seek out and accept offers of help, but expect some setbacks along the way and roll with the punches. And congratulate yourself when you achieve small gains. So that's it from me. Back to you, Vanessa.
Thank you so much, Kim, for that extremely informative presentation on a topic, like you said, that is often very difficult to talk about. We just have one question. How do I begin to talk to my partner about my intimacy concerns without appearing to be heartless and insensitive?
This was the best lesson I ever learned. It was when I was quite a few years ago now, and I was talking to a group face-to-face actually of couples with ovarian cancer. And we talked about how there are all sorts of changes that needed to be accommodated when you have treatment for cancer, but don't let sexuality go and make sure you keep addressing it. And we talked about most of the things that we've talked about in this presentation. And one gentleman said to me, "You've overlooked something, Kim." He said, "I just think I would be inconsiderate to expect my wife to be having sex with me after all that she's been going through." This was a couple in their 60s. She started to cry and she said, "All this time, I thought you didn't find me attractive anymore." And so I would say that if it's in your head, if you're thinking, how can we get back to where we were before with our intimacy, then ask that question. This woman wasn't asking the question because she thought she was undesirable. He wasn't asking the question because he thought he was being inconsiderate. And so it's a difficult conversation to have with the health professionals, but can also be a difficult conversation to have with your partner.
Absolutely. I guess it all comes down to communication, doesn't it?
Yep.
Very, very important.
Which is what Oliver said as well.
Yeah.
Bit of a common theme.
Thanks. Absolutely. Thanks so much again, Kim, for joining us on this webinar. I really appreciate your time.